So welcome everyone to High Rounds. I'd like to introduce Mr. Greg Millet. He is the Vice President at the American Foundation for AIDS Research, known as amfAR, and the Director of amfAR's Public Policy Office in DC. From 2000 to 2009, he served as a CDC Senior Scientist in the Division of HIV/AIDS Prevention. And then from 2009 to 2013, he served as Senior Policy Advisor in President Obama's White House Office of National AIDS Policy, where he helped author and implement the National HIV/AIDS Strategy. Mr. Millet delivered the opening plenary for the 2020 International AIDS Conference that contextualized 40 years of disparities throughout the HIV pandemic. And now, in the setting of the global COVID pandemic, Mr. Millet has led several key analyses that have addressed COVID-19 racial and ethnic disparities. Given his expertise in this field, we are thrilled to have him here today to discuss COVID-19 disparities in Black and Latino communities, implication for vaccine trial recruitment, a topic near and dear to my heart. So welcome, Greg. Thank you so much for taking time in your busy schedule to join us today.
No, thank you, Susan. It's really a pleasure to be here this morning. Good morning, everybody. Looking forward to speaking with you about some of the research that I have been seeing around COVID-19 disparities in Black and Latinx communities, and then also having a discussion about some of the implications that some of this might have for vaccine recruitment for COVID-19. So let's just go ahead and launch in. Now, all of us know that Black and Latino communities are disproportionately impacted by COVID-19, as well as the Native American communities. And this is basically a graphic that shows that, you know, African Americans only comprise about 12% of the population, but about 21% of COVID-19 deaths nationally, about 20% of COVID-19 cases. Latinx populations, 18% of the population, 21% of COVID-19 deaths, 29% of COVID-19 cases. And then in particular for Native American communities, 0.7% of the population, but 1.2% of COVID-19 cases, 0.9% of COVID-19 deaths. And then you compare that with white Americans who are 61% of the population, but comprise a smaller proportion of COVID-19 cases, 44%, as well as COVID-19 deaths. So this is something that we've seen, unfortunately, from the very beginning of the epidemic and is an enduring element of the epidemic through today. And then there's also these differences that we see when you adjust for race and ethnicity for every cohort, where you continue to see that COVID-19 rates for African Americans, for Latinx Americans in particular, are disproportionately higher, no matter what age cohort. So among those 85 plus, you see how high it is compared to Black and Latinx Americans in terms of COVID-19 mortality as compared to white Americans in particular. For those individuals who are 75 to 84, again, the same story compared with white Americans, all the way down to 30 to 49, which again, the rates of mortality are higher for African Americans and Latinos compared to white Americans. And there were data that came out recently where they basically said that risk of dying at age 50 among Black Americans is the same as the risk of dying among white Americans at age 65 for COVID-19, just to show the degree to which we're seeing these disparities and how that's even influenced by age nationally. And unfortunately, you know, the data that I was showing you was just taking a look at these disparities that we're seeing from ages 30 up. Unfortunately, we're seeing these disparities as well among youth. There have been a series of papers that have been published recently showing these disparities in infection as well as deaths among youth in the United States. And there's a one paper that was published in Pediatrics where they looked at data and COVID-19 diagnoses around here in the Washington, D.C. area, and they found higher rates for Latinx kids as well as Black children. And when they looked at this in terms of a trend analysis and dates over a period of time, this was something that was unfortunately enduring, where you could see for Black children that they were persistently higher rates of COVID-19 diagnoses over a course of several weeks. And then the same thing for Latinx children, with it actually increasing in terms of COVID-19 diagnoses over these periods of time. And unfortunately, you see the same thing when you take a look at COVID-19 deaths, where both Black as well as Latino children or youth have higher rates of COVID-19 deaths as compared to white Americans. So this is something that we're seeing irrespective of age, irrespective of race or ethnicity, and it's something that's incredibly problematic. And one thing that we've also noticed is the degree to which this has happened so early in the epidemic for COVID-19. So my colleagues and I published a paper in June, I believe, of this year, where we're looking at data as far back as April to take a look at the degree to which Black communities are at higher risk for COVID-19. At that time, 78% of the data were not disaggregated by race or ethnicity from CDC. So what we did was to take a look at those counties that had a higher proportion of African Americans to see if we saw greater rates of COVID-19 and greater rates of COVID-19 deaths. And what we found is that these counties that are disproportionately African American are only 22% of counties in the US, but they accounted for 52% of COVID-19 cases at that time, as well as 60% of COVID-19 deaths. And in terms of the distribution of these counties, 91% of them were located in the southern United States. As the numbers of African Americans increased, a proportion of African American residents increased in each one of these counties, there was a concomitant increase in COVID-19 cases as well as deaths. And as I had mentioned earlier, it was just striking that this took place as early in the pandemic as it did, because 97% of disproportionately Black counties had at least one COVID-19 diagnosis by mid-April, compared to only 80% of all other counties. Similarly, 49% of Black counties had at least one COVID-19 death by mid-April, compared to 28% of all other counties. And this is just basically a graphic that my colleagues and I produced at amfAR to really show the distribution of cases and deaths in disproportionately Black counties over a period of time, with the disproportionately Black counties being depicted in the orange, and all other counties in the United States depicted by blue. And you can see that these counties are primarily in the southern United States, but more importantly, that these disproportionately Black counties continue to this day to comprise 37% of cases nationally, as well as 45% of deaths, despite only being 22% of counties in the US. And it's not just among African Americans. As early as May as well, we saw these disproportionate numbers among Latinx populations as well across the US. And this is a really nice graphic from a paper that was published recently, where they took a look at many different states across the US, and they compared the proportion of Latinx populations within those states with the COVID-19 diagnoses at a period of time in May 20th within those states. And as you can see, the COVID-19 diagnoses eclipse the actual population of Latinx within these states. So they were disproportionately impacted by COVID-19. And we published a follow-up paper where we looked at Latinx counties. These are counties that were 18% or more Latinx in the US, to see if as early as May, we could see greater rates of COVID-19. And what we found when we put together some scatter plots was that there were some differences according to region of the US, that in the Midwest, there were higher rates of COVID-19 in those counties that were disproportionately Latinx, as the number of Latinx residents increased. And we saw exactly the same thing in the Northeast. We did not see any relationship in the southern region with disproportionately Latinx counties and COVID-19 and the number of residents who are Latinx. And we also didn't find that relationship in the West. But again, this was in May. When we take a look at those data now, we see that there are certainly some differences that have taken place as COVID-19 has diffused throughout the rest of the country. One of the things, though, that was really interesting, though, just to really put a finer point on it, is that in the Midwest region, Latinx counties were only 4% of counties in the Midwest, but they still comprise 32% of cases within our data. And in the Northeast, Latinx counties were only 11% of counties, but they still comprise 63% of cases among all of the cases in the Northeast. So again, showing how early on these communities were disproportionately impacted by COVID-19. Now, one of the things that we kept getting from reviewers when we were publishing our papers was whether or not this was a phenomenon that you're just seeing in urban areas that were at the time more highly impacted by COVID-19 as compared to more rural areas of the United States. And what we found was that that's actually not the case. So for our analysis for African Americans, we found that it didn't matter whether or not you were in a large central metro area or counties in a large central metro area that were primarily Black, medium metro areas, or even these non-core micropolitan areas, which are essentially rural areas. But that, you know, in these plots, you can see that COVID-19 cases were still disproportionately higher in counties with more Black residents, no matter the level of urbanicity as defined by the census. For Latinx counties in our Latinx analysis, we found something that was fairly different. We found that cases for COVID-19 were primarily elevated in medium metro areas all the way down to rural areas. So it's a fairly different pattern than what we were seeing among African Americans. And again, exploding this myth that this is only something that's taking place or driven by some of the cases that we're seeing in urban areas in the United States. Now, one of the things that's also very clear as well is the degree to which COVID-19 disproportionately impacts communities of color. And there are other diseases that many of us work in where we see exactly the same thing taking place. So for instance, many of us work in HIV, and you see, again, this disproportionate impact among African Americans, among Latinx Americans, American Indians, as compared to whites for HIV. And unfortunately, you know, life replicating itself now with COVID-19 and seeing this disproportionate impact within many of these same populations, which really prompts people to ask, well, why are we seeing these higher rates in communities of color? There's a really nice report that the National Academies of Sciences released last year, where basically they were taking a look at all of the data that were available to take a look at various interventions related to health, related social needs. And they found that healthcare accounts for some 10 to 20% of the determinants of health, whereas socioeconomic factors and factors related to the physical environment are estimated to account for up to 50% of the determinants of health. So essentially 70% of health determinants are due to physical, environmental factors, as well as healthcare. And not necessarily factors that are intrinsic to the individual or even underlying health conditions, et cetera. And I think that that's something that's really important for us to continue to take a look at if we have a hope of addressing COVID-19 or even HIV and many other diseases and dealing with health equity in our nation. Now, this is basically a slide that distills some of the data that we found in our first paper looking at African American counties and some of the predictors that were associated with greater rates of COVID-19 cases as well as mortality. And as you can see here, that those counties that had a disproportionately greater number of African Americans had higher rates of COVID-19 cases as well as deaths. The other things that were associated with greater rates of COVID-19 cases and deaths were percent uninsured within many of these counties, as well as household occupancy. Those people who lived in dense households had greater rates of COVID-19 cases. And there were also other issues that we found too, that those counties that had higher rates of unemployment had fewer cases of COVID-19. And a lot of that is because Black individuals are more likely to be essential workers, more likely to work outside of the home, more likely to come into contact with COVID-19. If you have higher rates of unemployment, then you're going to find that there's going to be lower rates of COVID-19. But the thing that was really telling and important that when we released these results that the news media didn't necessarily pick up upon, that we were hoping that they would, is that we found that there was absolutely no association between many of these underlying health conditions, which were definitely higher in Black communities, percent diabetes, heart disease, HIV, cerebrovascular disease, et cetera. All of the things that the media is talking about was associated with greater rates of COVID-19. That was not explaining the higher rates of cases or deaths in these disproportionately Black counties. And what was explaining it was really many of these social and economic conditions, these social determinants of health. And that's something that we spent a lot of time just really trying to dig into. This is from a paper that I published with Tonya Potier and Chris Byrer earlier this year, where we were mapping out some of these disproportionately Black counties, and we were looking at these higher rates of underlying health conditions. So you see the higher rates of heart disease, these higher rates of diabetes as well, and some of these heat maps. But the thing that many people were missing out upon is that there were also higher rates of social determinants of health, such as higher rates of poverty, of unemployment, of uninsurance, which is likely what was driving these greater rates of COVID-19, as well as other chronic and health conditions within many of these counties that unfortunately were receiving less attention. And part of the reason why we were seeing these same disparities among African Americans, among Latino communities, American Indians with the COVID-19 pandemic, as with other pandemics of the past. So to put a finer point on some of this, I just want to talk a little bit about some of these social determinants of health and how they're associated with greater rates of COVID-19. These are data from the New York City Department of Health, where they're looking at COVID-19 cases, hospitalizations, and deaths by poverty level in the US. And the one thing that you could see that's very clear, and I thought that this was well done, was that those places with those neighborhoods with the highest rates of poverty also had the highest rates of cases, highest rates of hospitalizations, highest rates of deaths for COVID-19, as compared to those neighborhoods that have lower rates of poverty, had lower rates of cases, hospitalizations, as well as deaths in New York City. This is something that we see replicated over and over again in the research literature. And I borrowed a slide from the National Institutes of Health from a study that looked at relative risk of all-cause mortality in the US by annual household income. And one thing that is very clear is that those households that make less than $25,000 per year had a 3 times greater odds of all-cause mortality, relative risk of all-cause mortality, as compared to those households that were somewhat wealthier. And you could see the same relationship with households that made $33,000 per year, with greater rates of all-cause mortality, relative risk, compared to households that were wealthier. So this is something that we see over and over in the US, that households and communities that are wealthier have lower rates of disease. And unfortunately, we see the same thing with COVID-19. There was a paper that was published in JAMA earlier this year where they found that COVID-19 mortality was 20 times higher in those counties that were more racially diverse, that had lower incomes, as compared to primarily white counties with higher incomes. So unfortunately, when we look at COVID-19, it's basically past this prologue. A lot of the patterns that we've seen for many other diseases, we're seeing over and over again. Now, what compounds this issue and makes it even more difficult is the fact that we're not only dealing with this disease burden within Black, Latino, as well as Native American communities, but we're also dealing with this financial crisis that's coming due as part of the COVID-19 recession that's unfortunately disproportionately impacting these same communities as well. So they're being squeezed on both ends. And these are data just taking a look at those individuals or households that are reporting serious financial problems during the pandemic. And you can see that it's most pronounced among Latino, Black, and Native American households relative to white households in the US. And there were more polls that were taken, this one from Kaiser Family Foundation, looking at the number of households or proportion of households that were reporting skipping meals or relying on charity due to the coronavirus pandemic. And you can see that 30% of Black households, 26% of Latino households relied on these types of means because of COVID-19, as compared to 8% of white households. And the disproportionate impact continues. There was a nice study from Stanford's Institute for Economic Policy Research, where they're looking at businesses by race, ethnicity, independent businesses, and really prognosticating what proportion are probably not going to survive because of the COVID-19 pandemic. And they found that Black businesses, about 41%, were not going to be able to survive the COVID-19 pandemic. About 36% of immigrant businesses, 32% of Latinx businesses, 26% of Asian businesses, relative to only 17% of white businesses. So we're having this disproportionate impact as well in terms of the economics of this COVID-19 depression, essentially, that's taking place, particularly in communities of color. And what that translates to as well is loss of insurance, which disproportionately is impacting many of these communities. This is from a paper that was published from one of the DC think tanks, where they were looking at the loss of insurance due to job loss by race and ethnicity, where they were predicting that as many as 10%, 13% of Blacks and Latinos, as compared to 6% of whites, were losing their employer-sponsored health insurance during the pandemic. This was an analysis that was actually done earlier on. I think this was May or so, and hasn't been updated since then. But other things that we're seeing too that are associated with the greater rates of COVID-19 in Black and Latino communities is basically some of the policies that the United States has had that unfortunately have endured over a period of time. Many of you know that after the Depression, there was a federal policy that basically instituted redlining, and they wanted to figure out which communities they should invest in to try and bring them back from the Depression. And explicitly within these documents from the federal government, you find that communities that were African American, communities that had a higher proportion of immigrants, they basically say, we are not going to invest in these communities. And unfortunately, that had an enduring impact, and an impact that lives on through today. So there are many studies that find that those communities that were traditionally redlined, those census tracts where we saw this redlining, where there was this underinvestment in those communities, that you see higher rates of cancer, you see higher rates of cardiovascular disease, you see higher rates of many other diseases. We were curious at taking a look at some of those data as well, but doing it in a different fashion. What my colleagues and I did was we took a look at those counties in the US that were primarily white, 88% white to 94% white, as compared to those counties that were more diverse, 60% or less white. And then of course we found that COVID-19 diagnoses were greater in those counties that were more diverse as compared to those counties that were primarily white. And then took it a step further. Many people, particularly here in DC, are very interested in the politics that's associated with this, and whether or not we see any differences between those counties that voted for Donald Trump, or states that voted for Donald Trump, and those that voted for Hillary Clinton. And what we found is that there really was no difference. Those counties that were primarily white in states that voted for Donald Trump had fairly low rates of COVID-19 diagnoses from the very beginning of the pandemic through, at the time this paper was published in June, through June, whereas those counties that were more diverse had higher rates of COVID-19 diagnoses, and that those rates actually exploded after we reopened the economy by around May 15th. You found the same thing for states that voted for Hillary Clinton, where you found these fairly low rates of COVID-19 diagnoses in those counties that were primarily white, as compared to those counties that were much more diverse and disproportionately Black, Latino, Brown, et cetera. And you notice here that even after reopening the economy, the only place where we see an increase in COVID-19 diagnoses is the most diverse counties as compared. Colleagues who are interested in taking a look at this, there was another paper by you where they found that cities and localities with greater Latino white segregation had higher rates of COVID-19 cases, as well as higher rates of COVID-19 deaths, as you can see by these scatter plots looking at these particular places and greater rates of Hispanic white segregation. So unfortunately, segregation is something else that also compounds some of these disparities that we see in COVID-19, and quite frankly, is something that we've seen for quite some time for many other diseases in the United States. The other thing that's been complicating the rates that we see in these communities is because many of these communities, there's high rates of undiagnosis of COVID-19. So very early in the COVID-19 pandemic, a lot of the testing for COVID-19 was placed in white and wealthier communities rather than in communities of color, where we were more likely to find more positives. So this is something that we saw in Tennessee. This is something that we saw in the neighborhoods of Philadelphia. We've seen it in Chicago. We've seen it in New York. There was an NPR analysis looking at cities in Texas where they found over and over again that COVID-19 testing was more likely to be placed in white and wealthier communities rather than in communities of color. And the problem with that is, of course, that we have higher rates of COVID-19 in communities of color. And essentially, we had the pandemic just fester within these communities because there were so many people who remained undiagnosed. The other policies that have been problematic, and I mentioned this a little bit beforehand, was reopening the economy and what COVID-19 looked like since we reopened the economy in May. Many of you might remember that we had this huge surge in the summer months in Texas, California, Arizona, and Florida. And there's just this surge in cases. We were really interested, and I know the New York Times also was interested in trying to explain why. And about the same time we were looking at these data, the New York Times published an article saying that the reason why we're seeing these higher rates in many of these areas is because of the proportion of the Latinx community in many of these states. And this is something that we were also interested in taking a look at. And just taking a look at the diagnoses during that period of time, it's very clear when you look at those counties that are disproportionately Latinx from the time that we opened the economy as compared to those counties that have a smaller proportion of Latinx populations. There is just this explosion of cases in Latinx counties in California, the same explosion in Florida, much greater number as compared to those counties that have a smaller proportion of Latinx. Same thing in Texas, and then of course nationally, where this policy of reopening the economy disproportionately impacted some communities of color as compared to other communities in the United States. And it's not just the reopening of the economy, it's even some of the policies that we have in communicating risk and communicating information around COVID-19. And there was a beautiful paper that was published in JAMA, as well as a paper that we published where we found higher levels of COVID-19 among monolingual Spanish speakers, where counties with higher levels of monolingual Spanish speakers in the US. And this publication in JAMA that basically found that there were higher rates of COVID-19 among non-English speakers compared to English speakers. And just a very nice study that was done, I believe in Washington State, where they looked at different types of languages spoken and these higher rates of seropositivity for SARS-CoV-2 for those people who basically spoke those languages uniquely and were not bilingual. And then of course you could see off the charts here for monolingual Spanish speaking, these very high rates of SARS-CoV-2. So another issue that has been a problem is the way that we communicate risk, the way we communicate the degree to which people might be at risk and how they can protect themselves for SARS-CoV-2, that we didn't do that uniformly in the United States. And it's actually part of a lawsuit right now in some Midwestern states where some meatpacking plants only communicated risk for SARS-CoV-2 in English and not in Spanish, despite the fact that they had a large number of monolingual Spanish speakers within those plants. And then we've seen the same thing, unfortunately, as well with detention centers, particularly detention centers for immigrants, where there are as many as 5,000 inmates and detainees who are infected with COVID-19 as early as May of this year. But many of these detainees were not being tested. So this is definitely an underestimate, particularly in these places where we see large numbers of immigrants who are of Latino descent. And then there was an outbreak that took place very close to here in Washington, D.C., where they found that 90% of the detainees actually tested positive for COVID-19. So when they did test, they found higher rates of COVID-19 in these detention centers that were just really left to spread like wildfire among inmates within these detention centers. The other thing that COVID-19 is doing is it's going to upend this Latino paradox that we've had and that we've seen for quite some time. So the Latino paradox is essentially that you see greater life expectancy, particularly among immigrant Latino populations as compared to native white populations or Black populations. And it's something that has been observed for quite some time. It's been discussed in the literature for quite some time. But there was a new paper that was taking a look at life expectancy due to COVID-19, where they're seeing this precipitous drop in life expectancy among Latinx populations relative to whites. And this disappearance of this paradox that we have observed for, since the 1980s, and particularly immigrant Latinx populations, and the fact that that's actually diminishing, if not disappearing, because of COVID-19 and the impact of COVID-19 in Latinx communities. The other thing that has been interesting to see as well is that not all Latinx communities are at equal risk for COVID-19, just like not all Latinx communities are at equal risk for HIV. And to see papers coming out that Puerto Rican communities, Central American communities in particular, have greater risk for COVID-19 as compared to Mexican American or South American communities. So something else for us to consider in some of the work that we do, and as well as some of the targeting and strategies for some of these communities of color. But all of this is to say that, you know, as scientists, we should have seen this coming. We already knew as far as 10 years ago that H1N1, is another respiratory illness, disproportionately impacted Black and Latinx populations, as well as American Indians. These were data from CDC taking a look at hospitalization rates for H1N1 that were elevated in these communities of color as far back as 2009 and 2010. And with colleagues publishing earlier this year that they were hoping that COVID-19 would be different and that we'll be able to get on top of these disparities before the pandemic spread. But unfortunately, we didn't. And where we are right now is a point of complete devastation that's taking place in many of these communities. And unfortunately, it's unabated. So we're experiencing a surge right now in terms of COVID-19 cases and deaths, and we're reaching unprecedented levels in terms of daily reported cases, hospitalizations, as well as deaths. And I was just curious, just tracking some of the data on a tracker that we have as part of our website to see how this is impacting disproportionately African-American counties. And what you can see is that over the past 2 weeks, that there's been a 15% increase in all other counties in the US, in the southern US, as compared to a nearly 18% increase in African-American counties. When it comes to deaths, there was a 1.29 increase in all other counties in the southern US, whereas there is a 13% increase in deaths in disproportionately Black counties. So we're seeing that disproportionately Black counties, particularly in the southern United States, are perhaps faring worse in this current surge, and something that we were interested in taking a look at as this continued. We're seeing the same thing on the West Coast as well for those disproportionately Latinx counties, that there was actually a decrease in all other counties over the 2-year period or 2-week period in terms of COVID-19 cases, but then a 30% increase in disproportionately Latinx counties. And you can see that here as well. And then taking a look at deaths, again, the change over the 2-week period was about 24% increase in all other counties as compared to a 40% increase in disproportionately Latinx counties. So all of that to say that this surge, again, is also a surge that is going to affect communities of color disproportionately, just like we saw earlier on in the pandemic, which is a shame. Now, as I come to the close of my presentation, I just wanted to make sure that people understand that these types of disparities that we're seeing in terms of COVID-19 cases and deaths by race and ethnicity, we're actually seeing it in many other places across the world. We're seeing it in Canada and Europe and in South America. And I just wanted to show some data around that even in Nordic countries, so for instance, in Norway, 15% of residents were born abroad, but they accounted for 25% of COVID-19 cases. And most of this was taking place within the Somali population in Norway. There were 425 cases, and that Somalis were 6% of these confirmed cases, more than 10 times their share of the population. The same population was at higher risk in Sweden. About 5% of the cases between March 13th and April 7th, again, very early in the pandemic, was among immigrants in Sweden. It was 7 times their share of the population in Sweden. So it's taking this disproportionate toll in these specific communities again. In Toronto, we're seeing exactly the same thing where Black residents of Toronto comprise 83% of reported COVID-19 cases. And these were data from August of this year. And they did a really nice chart of taking a look at the proportion that these communities are of the Toronto population. So for Arab Middle Easterners, 4% of the population, 11% of COVID-19 cases. Blacks, 9% of the population, 21% of COVID-19 cases. Latin Americans, 3% of the population in Toronto, 10% of COVID-19 cases. South Asians, 13% of the population, 20% of COVID-19 cases. Southeast Asians, 7% of the population in Toronto, 17% of COVID-19 cases, as compared to whites, who were 48% of the population in Toronto, but only 17% of COVID-19 cases. So again, some of the things that we've seen in the US is being replicated in many of these other parts of the world. We're seeing the same thing in South America, in Brazil. And again, these are data that were very early on in the pandemic, from April 11th through May 25th, where you could see this decrease in COVID-19 hospitalizations among white Brazilians, but then this increase in cases over that same period of time in hospitalizations for COVID-19 among Black Brazilians. The same thing with COVID-19 deaths, a decrease in that period of time among white Brazilians for COVID-19 deaths, and then an increase in deaths for Black Brazilians. And then over this period of time, these are some of the trend analyses where you could see these increases in hospitalizations among Black Brazilians, and then a decrease over that period of time for white Brazilians. And then again, this increase in deaths over that period of time for Black Brazilians as compared to a decrease in white Brazilians. So again, to show that this is not just a phenomenon that we have in the United States, this is something that's taking place internationally. The other thing that's really important to take a look at too is the degree to which the social determinants of health are not only impacting these cases domestically, but also internationally. So these are some of the data from Toronto where they're looking at COVID-19 cases by household income. And you could see that those household incomes that went from 0 to about 29,000, 29K per year, that they were 14% of the Toronto population, but they were 27% of cases. So this is sort of the poor group. Those groups that made as much as $150,000 or more, they comprised about 21% of the Toronto population, but much fewer cases, only 6% of cases. So again, that dynamic of income and disease morbidity was something that we're seeing very closely in Toronto. And you see the same thing in Brazil by education level. Those individuals who are in the lowest or no education group, you see a very high rate of death. 71% of these cases were these people died within these lower education groups, as compared to people who had the highest level of education in Brazil, where only 22% had died within that higher level education group. And I think the place where we see this more strongly is in the UK, where they have much more complete data reporting that we do in the US, where they actually have information by race and ethnicity for nearly each case, where you see higher rates of COVID-19 deaths among Blacks in the UK, among Pakistanis in the UK, Indians, for men as well as for women. And then more importantly, there have been analyses coming out of the UK that really mirror some of what we see in the US as well, that after they adjust for socio-demographic characteristics, such as income and other characteristics, that it dramatically reduces the odds of deaths of COVID-19 patients by race and ethnicity. So again, there's something that's taking place within these social determinants of health that's placing communities of color at higher risk that we really need to address if we want to deal with COVID-19, HIV, and other diseases. So what are the implications for COVID-19 vaccine trial participation? Well, we know that we've had these longstanding issues of mistrust among African Americans for quite some time, and particularly in the HIV space. And there's been great work that Lisa Bogart and many of her colleagues have been doing for quite some time. One of the largest studies and one of the first studies I know that she published on this issue was from 2005, where they saw high proportions of African Americans who believe that a lot of information about HIV is being held back from the public, that HIV is a man-made disease, that there's a cure for HIV. And of course, the issue with having these conspiratorial beliefs is that it's associated with people less likely getting tested for HIV. If they do test positive, less likely to take medications for HIV or to be virally suppressed. But the thing that's really important about this is just how enduring these beliefs are and this mistrust is. because Lisa Bogart 13 years later published another study. It was a similar analysis, I think using a similar data set of a national sample, where they found, a high proportion of African Americans still believe that HIV is man-made, 31%, and about 40% believe that the government is withholding a cure for HIV. So the numbers were somewhat lower as compared to 13 years before, but still a significant proportion of the community that subscribed to these beliefs. And they subscribe to these beliefs for a very good reason. Many people like to cite Tuskegee, but quite frankly, we even have more recent issues in terms of racial discrimination by looking at the opioid epidemic and the fact that there have been many studies, including those published in New England Journal of Medicine and Pediatrics and others, showing that doctors are far less likely to prescribe opioids to African Americans as compared to whites, believing that African Americans will be able to withhold the pain more, or believing that African Americans would be more likely to be addicted to opioids. So, because of a lot of these issues in treatment of the medical community, there is justifiably high levels of mistrust. And that high level of mistrust is translated, of course, into COVID-19 vaccines. As early as April and May, when Pew Trust was taking a look at polls of the American public, they found that a greater proportion of whites as well as Latinos said that they would definitely probably take the COVID-19 vaccine as compared to only 54% of Black Americans. When you go a little bit later, these are data from Kaiser Family Foundation between August and September of 2020, you find that about 37% of Latinos say that they would definitely take the vaccine, as well as 37% of whites, as compared to only 17% of African Americans. And then as you go into early October, we see this huge decrease among white Americans, but particularly among Black Americans as well, as to whether or not people would definitely or likely to take a vaccine, the COVID-19 vaccine, as it becomes available. With Black Americans, as many as about 65% in mid-August saying that they would take it, and then that going down to about 40% in their poll by early October. And the thing that we have to realize, and this is a great paper that one of my colleagues, old colleagues from CDC and an old neighbor, we had adjoining offices, Lisa Grovecoff, published in JAMA, where you see these fairly low vaccination rates for just common flu. But that remains low among Blacks, Latinos, and American Indians compared with whites in the United States. And you take a look at vaccination coverage in 2017 and 2018 and 19, it's still fairly low in many of these communities compared to the overall rates of vaccination coverage, and something that we all need to work on. So this is an issue that really predates COVID-19 that we knew was going to be an issue. I think one of the things that we also have to be attentive to when we're thinking about recruitment is the degree to which many of these communities remain stigmatized, despite the fact that they're doing everything possible to keep themselves from getting COVID-19. So even though you see in various polls that Black Americans have much higher rates of mask use, same thing with Latino Americans as compared to white Americans, that Black Americans are more likely to social distance and to take other precautions against COVID-19, we're still more likely to get COVID-19. And it's exactly the same thing that we've seen in HIV, something that I've published on and many other colleagues have published on for quite some time, that even though African Americans are more likely to engage in have fewer sex partners, be more protected with their sex, we still have higher rates of HIV. It's a paradox that we've seen for quite some time. The problem, though, is that there's still this scapegoating that takes place in the media and other places when they see higher rates of disease within many of these communities. The implicit question is, what are these communities doing that's wrong? And that's the wrong question. The right question is, what are some of the things that are placing these communities at higher risk, despite the fact that they're doing a lot of things that's right? And I think the last thing to say is that the messenger matters. There's another survey by Ipsos Axios that found that barely 2 in 10 Americans would take a COVID-19 vaccine if President Trump declared it safe, as compared to 60% who would take it if their doctors declared it safe, or 54% saying that if the FDA declared it safe. So we really need to recognize that the messenger matters. We need a credible messenger for the COVID-19 vaccine in order for us to be able to recruit some of these communities into the vaccine trials. The other thing as well that's important is, many of us learned in public health school, Maslow's hierarchy of needs. If we're dealing with communities that are systematically being debilitated by not only COVID-19, we're seeing high rates of cases and deaths, but also loss of jobs, loss of livelihoods, people who are being kicked out of their homes, that we're going to have to address their basic needs first before even considering trying to recruit some of these individuals into trials, because thinking about recruitment in trials is perhaps the least of their concerns as compared to perhaps finding a home for their family or providing food on the table for their family as well, and something that we need to consider. There are other leverage points, though, for recruitment into COVID-19 vaccine trials. So we need to be as transparent as possible. We need to depoliticize the process and some of the science over that's taken place, the politicization that's taken place over the last few months. We might have an opportunity with the new administration. If there's a new administration, are we probably going to see more trust in some of these COVID-19 vaccine trials as compared to the very little trust that we've had with this last administration? I frankly think that it was great that the trial results have been released after the election. That really helps to take the air out of some of the politicization that's taken place, and that actually might increase the likelihood of communities of color willing to participate. Of course, many of you are already thinking about some of the influencers in the Black community, from the morning show hosts to sports stars, musical artists, as well as HBCU representatives, and some of these people who would be more helpful in trying to move the ball forward and trying to get communities to participate in these trials. Of course, one of the big issues that we see in public health is that we have to have these enduring relationships with communities of color. We can't just parachute in and out of communities when we're about to do these types of trials. There needs to be an established relationship that's there. There needs to be this established trust that's there, so that we can work in these communities over a period of time. And a lot of this we've learned from our work in HIV, where you have to have this continuous engagement. I think the other thing that's going to be important is, volunteer testimonials. Are we able to really put up testimonials of African Americans, Latinos, and others who have volunteered to be a part of these trials? And I think perhaps the more important testimonials are testimonials from people who were adamantly opposed to vaccine trials, who might have changed their minds. And that's something that we're going to see happen. So for instance, the heads of the historically Black colleges and universities already announced earlier this summer that they were adamantly opposed to participating in vaccine trials. I suspect that that's going to change at some point in the future. And when it does, it would be really important for us to highlight those individuals who beforehand were opposed to the trials, who have now changed their minds, because it gives much more credibility for trying to recruit members of these communities into trials, when there are people who at first thought that if they were not safe, and then immediately changed their minds and said, yeah, this is something that's safe, this is something that I'll consider doing. I think, though, that one of the biggest things that we have is the fact that President Obama is going to be taking the vaccines, or one of these vaccines, in the very near future. Vice President Kamala Harris is going to be doing the same, and that's also going to be important in trying to turn around some of the attitudes and some of the mistrust that's taking place within Black and Latino communities towards recruitment in these trials. So in summary, communities of color are at greater risk for COVID-19. These disparities appeared early, and unfortunately they're enduring. We see these same disparities through today. The same disparities are also observed for other health issues, such as HIV and many other health issues. We're following a predictable pattern. The failure to address the social determinants of health helped to reinforce these disparities. And the COVID-19 pandemic affects communities of color both financially as well as in terms of disease burden. There's also several policies that magnify this risk. I only talked about a couple, such as reopening the countries too soon, segregation, lack of testing in communities at highest risk. Other policies are, Medicaid expansion and the Affordable Care Act, and whether or not we're going to be able to have the Affordable Care Act in the future. That's certainly going to affect the risk, the greater risk in communities of color. The latest COVID-19 surge may impact communities of color most. That's something that we're probably going to see. And COVID-19 racial disparities are also evident in other countries. This is not a unique experience to the Americas. We're seeing it in many other continents and in other countries as well. And then last, recruitment in vaccine trials is possible despite this mistrust. And there are things that we can do around that. Before I end, I just wanted to acknowledge some of the colleagues for some of the papers that I published earlier this year, and some of of the data that I presented from this analysis. Just amazing group of people that I love working with, and it's really been an honor publishing with them with some of these analyses. And then this is just my last slide with my information. You can reach me at that email, as well as a URL to a dashboard that we have where we've been tracking COVID-19 cases and deaths by race and ethnicity across different counties in the United States. So thank you again for the opportunity to speak, and look forward to any questions that you might have.
Thank you so much, Greg. Sorry, I joined a couple minutes late. There were a lot of questions that came up, and I think some got answered. I'm going to try to just work my way through them. If you're able to see the chat, it may help you, but I'm going to try to read some of these to you. So the first question was related to when you were talking about the metro areas. And the question was around any sense of employment type as a risk factor for acquiring COVID. The person posited that factory jobs and other occupational risks might impact Latinx and other individuals.
Absolutely.
Facilities too, yeah.
Absolutely. There was a fantastic paper that was published in Health Affairs, I believe 2 or 3 months ago, and I didn't show that slide, but they basically looked at the proportion of people who were essential workers in Black and Latino communities, and they looked at specific jobs such as transportation, such as healthcare work, and other jobs. And basically showed that I believe it was close to 60% of Latinx households had at least one person in that household who could not work from home. They were an essential worker. About 45% of Black households had somebody who could not work from home. They were essential workers, as compared to about 27% of white households who had someone who could not work from home. So, the type of jobs that people do certainly influences the risks that we see. There's another paper that was just published, I think 2 weeks ago. They were looking at COVID-19 in New York City. And one of the things that they found is that the proportion of essential workers within neighborhoods of New York City was associated with greater rates of COVID-19. And they also found that in many of those neighborhoods, they were Black and Latino neighborhoods. So absolutely, the types of jobs that people have, the types of opportunities that they have are certainly associated with these higher rates of COVID-19.
Thanks. So another question from one of our faculty. She noticed on the first slide that the case rate is very high among Latinx population, but the death rate is not as high when compared to the death rate among African Americans. Do you think this is related to income, employment? What do you think it's related to?
It's actually related to something that's a little bit more simpler. You see that with Latinx communities that they're actually a younger community compared to white communities, as well as Black communities. And of course, what we've been witnessing with COVID-19 is that it impacts youth in terms of deaths far less as compared to older communities. So that's part of the reason why we're seeing the death rate not as high in Latinx communities compared to Black and Latinx communities. And this is something I speak about with my parents all the time. My family is Cuban and Panamanian. I'm first generation American, and I call my family in Central and South America to ask them how things are going down there. And it's something else that they're witnessing in many of those areas as well, where the death rates are not as high, thankfully, despite that COVID-19 is still disproportionately high with some communities.
That makes a lot of sense. Thanks. This talk was so incredible, but I have to say a little bit depressing. I'm trying to, there was a question sort of in the direction of maybe what we can do. Let me just find it. Sorry, there was a lot coming out. It's a fast-moving pandemic amidst hundreds of years of structural inequities and inequalities. What hope is there to reduce those disparities? What sort of mitigation strategies can and have worked?
Yeah, there are certain things that we can do now. So, if we take a look in the HIV space and we look at the Ryan White program, the disparities that we see in Ryan White by race and ethnicity in terms of viral suppression have actually been decreasing over a period of time. And these disparities are far better for those people who are HIV positive in the Ryan White program. You see smaller disparities as compared to HIV positive people who are not in Ryan White. And the reason for that is because we have all these wraparound services that are also associated with the Ryan White program. So you have access to healthcare, child care services as you're getting your healthcare. You have transportation to healthcare services. You have transportation even to legal issues to help address access to medications, et cetera. All of these things that really kind of address the social determinants of health have been important in reducing disparities in Ryan White. I think the other thing that we can consider as well too is access to health insurance, something as basic as access to health insurance. When we were working on the National HIV/AIDS strategy in the Obama White House, we were very clear that the strategy was not going to work on its own. There was no accident that it was released a month after the Affordable Care Act was introduced. We knew that access to healthcare was going to be instrumental for us to make the goals that we had for reducing HIV infections and increasing care under the National HIV/AIDS strategy. And it's also something that is going to be instrumental as well for COVID-19. There was a recent analysis, and I didn't show this in our slides, but there's a recent analysis that looked at those states that have not expanded Medicaid. There's about 14 of them in the United States, and how many more people would be insured, particularly essential workers. And they found that 650,000 essential workers would be insured if those states, those laggard states, expanded Medicaid. Those essential workers are primarily Black and Latino communities. So that would make a big difference as well for COVID-19. I think the last thing that makes a difference too is just taking a look at models of health equity. So when you take a look at the Army or even the VA, there are specific things that they've done right. There's been an emphasis to really try and drive out racism and racial inequities. And you see that in terms of the care that people receive. So there have been a slew of papers that are produced showing that a lot of disparities are lower in the VA between whites and Blacks as compared to the general population. And there was a paper that I highlighted months ago that I think has since been published where they followed 6,000 veterans in the VA. And they found disparities in terms of COVID-19 cases and deaths with higher rates among Blacks and Latinos, but they found no difference in mortality by race and ethnicity, which I think is astonishing because you see these big rates, big differences in mortality in the general population. And what I think is taking place there is because of the care in the VA, because of the emphasis on health equity, that we're not seeing as high rates of poor outcomes with COVID-19, despite the fact that we're seeing differences in terms of disease acquisition. So there are specific things that we can do now. The last thing is, of course, make sure that testing is actually concentrated in communities that are most impacted by COVID-19. So all of those things would be helpful to help move things forward.
Hey, Jill, can I take the liberty of asking one last question
Please,
since time is late?
I was just about to say that, yes.
So Greg, I'm going to ask you to put your policy hat on. So one of my concerns is, as you mentioned, which I strongly endorse, don't parachute in. But I will also counter with, we have a very accelerated time crunch. Emergency use authorization vaccines are imminent. And some beautiful modeling has been done around the time frame in which we need those vaccines implemented, if in fact we're going to achieve herd immunity in any reasonable time frame to limit epidemic spread. And so we're not going to remove all of the mistrust that exists in communities of color. It's a huge problem. So I guess the question is, I think it would be great when Obama and Kamala Harris get their vaccines. That's not enough. We need to address the social determinants of health. So what policy changes can be implemented to significantly overcome some of these challenges that could help us in the time frame that we need to try and help us achieve the goals that we need?
And I think that that's the biggest problem is that, by definition, policy level interventions or some of these higher level interventions, they take time. They take time to diffuse, they take time for us to actually implement them or even to be passed in various legislatures. And I think, the problem is that we were just inadequately equipped to deal with the magnitude of these disparities and the degree to it and the time frame that we were given to really address these disparities. So, I mean, it's the long answer to that question is that there really is very little that we can do very quickly. That all of that, unfortunately, takes time. I've watched some of the policies that I've been involved in, the national policies, have all taken a long time to address, to get out, to implement, to roll out, for us to start trying to make an impact. And unfortunately, it's going to be the same thing with COVID-19.
Okay, on that happy note.
Sorry. It's a $60,000 question, and I wish that I had a better answer, but it's unfortunately, the world that we're living in at the moment.
Yeah.
Hopefully, we will be better prepared in the future.
Okay. Well, thank you so much. This was an outstanding talk, and at least gives us an outstanding lay of the land and the hurdles that are in front of us. So thank you very, very much. I appreciate it.
Thank you. It's
Thank
a pleasure.
you. Wonderful praise in the chat box. So take a look.
Yeah.
Thanks so much.
Thank you.
Okay,
Bye-bye.
thank you. Bye-bye.